All right, welcome once again, and let's start with the second part of bacterial meningitis. And in this part, we will look at the treatment. We will discuss the treatment of bacteria mainly, and in the end, I have some slides that show the treatment of viral meningitis, but that is for your self-study. We will not go into the details. There are just one or two slides. So treatment of bacterial meningitis, the goals of the treatment, like any other disease or like any other infection, eradication of the infection is the first goal, ameliorating the signs and symptoms when the patient has the disease. That is our second goal, and you will notice that we have these goals in almost all diseases. Then prevention of complications, morbidity, and mortality. Initiating appropriate antimicrobials as soon as possible, providing supportive care, which is again very important in every disease. Then prevention by vaccination and chemoprophylaxis. We have 2 or 3 vaccines, and we use some antibiotics when someone comes in contact with the index case or with the person who is infected or who is suffering from bacterial meningitis. So read this slide carefully. This is just for the lecture. I'm not going to ask you a question during this session. So there have been significant changes in treatment strategies for community-acquired bacterial meningitis. The introduction of Haemophilus influenza B vaccines in Europe resulted in virtual disappearance of H. influenza type B. So as a result of that, now this infection is more common in the adults. And there is also a conjugate pneumococcal and meningococcal vaccines that have substantially reduced the burden of bacterial meningitis. So we have got these 3 vaccines, and as a result of this vaccination, community-acquired bacterial meningitis has become a disease that currently affects more adults than infants, because this HIV vaccine is usually given to infants, and we'll come back to this point later on. And there is an increasing rate of resistance that is a bit unfortunate to common antimicrobial agents among strains of strep pneumonia, which is also known as pneumococcus, and meningitis, Neisseria meningitis, which is also known as meningococcus. But as you will see that we have not many drugs, right? I can just name a few for you. Vancomycin is there, ceftriaxone is there, penicillins are there, and cefepime is there, depending upon whether it is gram-negative or gram-positive, but we'll go into details a little bit later, okay? So approach to treatment, if the patient is in shock, you have to administer crystalloids until you achieve a euvolemic state. If the person is hypovolemic, then you have to achieve a normal circulating volume through crystalloids. And you know that we have done it so many times that crystalloids are better than, or are the preferred intravenous fluids over colloids. You know, the colloids are very expensive and they have no therapeutic benefit over crystalloids. If the patient's mental status is altered, seizure precautions should be considered. According to the usual protocol, airway protection should be established. If the patient is alert and in stable condition with normal vital signs, oxygen should be administered, IV access should be established, and rapid transport to the emergency department should be initiated. In acutely ill patients, antibiotic therapy should be initiated promptly. But in many cases, as you'll see in the guidelines, that steroids are considered, you know, they are given before the first dose of the antibiotic. So dexamethasone, we'll come to the doses later on, and just to remind you that the doses that are in the slides will be on the test, although in this lecture, there are some tables that you have to memorize, because that is what you have to do in therapeutics as far as bacterial meningitis is concerned, and those are not very difficult to memorize tables. The drugs in all those tables are more or less the same. If there is sign of hydrocephalus and increasing intracranial pressure, you should watch for it. Okay, you should be careful, and you should know as soon as there is a tendency to develop increased or raised intracranial pressure. Fever and pain should be managed. Straining and coughing should be controlled in view of this increasing intracranial pressure. Okay, and again, seizures, they can lead to seizures as well. They should be prevented. Hypotension should be avoided. Again, hydration is important over here. In otherwise stable patients, sufficient care includes elevating the head and monitoring neurological status. So a case of bacterial meningitis is a serious case. He is either in the emergency department or he or she is in ICU, where the monitoring is usually quite sufficient and quite extensive. When more aggressive maneuvers are indicated, some authorities favor use of diuresis, but again, you have to look at the circulatory volume, okay, the fluid status of the patient. And to use diuresis, for example, in raised intracranial pressure or in case of hydrocephalus or cephalus, I don't know what the correct pronunciation is. I think it is hydrocephalus. But anyway, furosemide 20 milligram intravenous or mannitol 1 gram per kilogram intravenous, they can control or they can be used to induce diuresis. Okay. Then subacute meningitis, if you remember, we said that 1 to 7 days or 2 to 7 days is subacute meningitis when the symptoms appear in 2 to 7 days. Now here, what we are saying is that the symptoms have been present for more than 5 days. Patients with subacute meningitis are more commonly immunosuppressed. They have comorbidities. They have fungal etiologies. They have higher rates of hypoglycorrhea, which means glucose less than 40 milligram per deciliter in the cerebrospinal fluid. And just to remind you, and this is an important point that we said earlier, that the normal glucose level in the cerebrospinal fluid is about 60% of the serum glucose level, the blood glucose level. For example, if the blood glucose level is 100 milligram per deciliter, then the normal CSF level should be 60 milligram. But if it is less than 40 milligram, then we call it hypoglycorrhea. These people have abnormal neurological findings than patients with acute meningitis. And then patients with subacute meningitis are less likely to be treated empirically with intravenous antibiotics. So that is just an epidemiological observation. And also because of the signs and symptoms, they are not as acute as in acute meningitis. They have lower levels of CSF pleocytosis, and pleocytosis means increased number of WBCs. So both in the CSF and in the serum, the WBC counts are lower than patients with acute meningitis. All right, so the treatment of bacterial meningitis, it is a neurologic emergency that is associated with high rates of morbidity and mortality. And the bacteria include meningococcal meningitis, H, influenza meningitis, staphylococcal meningitis, and initiation of empiric antibacterial therapy is therefore essential for outcomes. So empiric therapy, we will see what it is. You know, I've already mentioned a few, like vancomycin or penicillins or ceftriaxone. You can go on to cefepime or meropenem, depending upon the cases. So the next few slides will present in a tabulated form the recommended empiric antibiotics for suspected bacterial meningitis according to age and predisposing factors. And you have to know all of these tables. So here is the first table, age 0 to 4 weeks, ampicillin plus either cefotaxime. So cefotaxime will come again and again, cefotaxime, okay? Here it is cefotaxime, ceftriaxone. So what you see over here is when the age is 0 to 4 weeks, it is ampicillin plus either cefotaxime, and aminoglycosides are synergistic in combination with penicillin, so you can use that. Now, 1 month to 50 years and age more than 50 years and impaired cellular immunity, recurrent meningitis. So in these different situations, we have vancomycin, even in head trauma. And you know that vancomycin covers gram-positive bacteria. Vancomycin plus cefotaxime, ceftriaxone, okay? Here we have got cefepime, but cefotaxime, ceftriaxone. Then in head trauma, we can have ceftazidime, which covers Pseudomonas, and meropenem also covers Pseudomonas. Cefepime is 4th generation. All the others are 3rd generation cephalosporins, right? So what we have seen is that it is vancomycin, and here I've given you the most common drugs, which are vancomycin, cefotaxime, ceftriaxone, and ampicillin is there, particularly in 0 to 4 weeks, and when Listeria monocytogenes is misspelled, and it is also not italicized anyway. That's a mistake. I'll correct that. So these are the drugs, and the other drugs are cefepime, meropenem, ceftazidime is also there, which cover, and all these drugs, these 3 drugs, they cover Pseudomonas. So if you are suspecting gram-negative, you may start with these drugs. And even cefepime and ceftriaxone, they have very good gram-negative coverage. If you remember these cephalosporins, as we go from 1st generation to 2nd to 3rd, the gram-negative coverage increases and the gram-positive decreases. And in 4th generation, the gram-positive coverage returns. So cefepime has got good gram-positive and gram-negative. This is 4th generation. We have 5th generation as well. Ceftaroline is one of the examples, but that's not over here. Right now, here is another way of looking at the antibiotics. Antibiotics are the same, right? Cefotaxime, ceftriaxone, chloramphenicol is there because chloramphenicol crosses the blood-brain barrier very rapidly. So we are looking at the minimum inhibitory concentration. Okay, now over here, the minimum inhibitory concentration is less than 0.06 microgram per ml, which means that this S. pneumonia is highly sensitive to penicillin. So we give penicillins, penicillin G or ampicillin. Okay, penicillin G mostly covers gram-positive. Now here it is the minimum inhibitory concentration is higher, more than double of this one. Now here, this is not, penicillin is not a very good choice, okay? Cefotaxime or ceftriaxone, this is also pretty high. Okay, so we can either give cefotaxime or ceftriaxone, or we can go on to cefepime and meropenem. Now, over here, what we have again is pneumonia. It's a gram-positive, and it is alpha-hemolytic. So cefotaxime, again, higher minimum inhibitory concentration, right? So we go on to vancomycin with cefotaxime or ceftriaxone, or we can go on to vancomycin plus moxifloxacin. Now, in case of H. influenza, where beta-lactamase resistance is a problem. So if it is beta-lactam resistance, right? So it has got beta-lactamase, which will destroy the beta-lactam ring of the antibiotics. So if it does not have this enzyme, then we can use beta-lactams like ampicillin, cefotaxime, and ceftriaxone. We have got over here because they are resistant to beta-lactamases, right? So remember that the third generation cephalosporins are mostly resistant to beta-lactamases. Even the fourth generation is resistant to that. Cefepime is fourth generation, right? But if there is ampicillin resistance, then we go on to meropenem, and fourth generation is cefepime or chloramphenicol or aztreonam or fluoroquinolone, right? So this is in general. I hope you have understood what the basic what the basic algorithm for choosing an antibiotic is. In some bacteria, we look at the minimum inhibitory concentration. If it is very high, it shows some degree of resistance to the bacteria or the production of beta-lactamase enzyme, right? Now, in meningitis, again, we are looking at its sensitivity to penicillins. If it is less than 0.5 microgram, see it is more than this, but still very low, then we can give penicillin G or ampicillin. But if it is more than 0.1 microgram per ml, that means that it is not very sensitive to penicillin. So we again go back to cefotaxime, ceftriaxone, and we have alternative drugs, same as we had in the previous slide, okay? Then Listeria monocytogenes, penicillin G, strep A galactiae, penicillin G or ampicillin, Enterobacteriaceae, which includes E. coli as well. Again, cefepime, ceftriaxone. So the bottom line here is Pseudomonas aeruginosa. So we have to give ceftazidime. And there is another third generation. This is also third generation that covers Pseudomonas, and that is cefoperazone. But unfortunately, cefoperazone does not cross the blood-brain barrier. So we use ceftazidime or cefepime, and we have got these alternative drugs as aztreonam and meropenem and ciprofloxacin. And again, as epidermidis, which is coagulase negative. So we get, but it is gram positive. So vancomycin is there, linezolid is there, all right. And you have to know the duration of treatment as well, as I mentioned previously, that I can give you an antibiotic or a bacteria and ask you the duration of treatment as well. Now, CSF levels of antibiotics, it depends. There are some antibiotics that cross the blood-brain barrier at all times. There are others that cross the blood-brain barrier only when the meninges are inflamed and the capillaries in the brain become more permeable. And then there are some that never cross the blood-brain barrier. Aminoglycosides is one of those, okay? So it depends upon the lipid solubility of the drugs. If the drug is lipid soluble, it is non-polar, it is non-ionized, it can cross the lipid membranes. Molecular size, large molecular size. Vancomycin is a very large molecular size antibiotic, but when the meninges are inflamed, it does cross the blood-brain barrier. Protein binding capacity, anything that is bound to protein is not bioavailable, okay? It does not cross membranes. It will not be excreted by the kidneys, and it will not be metabolized. Patient's degree of meningeal inflammation, the more the inflammation, the higher will be the permeability of the capillaries. And penicillins, third and fourth generation cephalosporins, carbapenems, fluoroquinolones, and rifampin, they provide a high CSF level. Rifampin and some other tuberculous drug, chloramphenicol, they cross blood-brain barrier all the time. TMP, SMX, sulfonamides, So monitoring and at times obtaining serum drug concentrations may be necessary to ensure adequate levels and to avoid toxicity in drugs with narrow therapeutic indices, for example, vancomycin and aminoglycosides. And this is especially important in cases of renal dysfunction, okay, particularly the drugs with narrow therapeutic indices. So here is a list of drug, and it's written that this slide will be on the test. Nothing difficult, therapeutic levels in CSF with or without inflammation. So these drugs will cross the blood-brain barrier at all times: chloramphenicol, sulfonamides, the antituberculous drug metronidazole. Although over here, we do use rifampin under certain situations. We have seen chloramphenicol as well, although it is very toxic. We try to avoid it. Then these drugs, we can achieve therapeutic levels in the CSF with inflammation of the meninges. So meningitis means inflammation of the meningitis. So in cases of bacterial meningitis, these drugs can be used under normal situations or circumstances. They do not cross the blood-brain barrier. But in meningitis, when the meninges are inflamed, all these penicillins and third generation cephalosporins, although this ceftriaxone is second generation, vancomycin, ciprofloxacin, linezolid, they will all cross the blood-brain barrier. And then there are some drugs that never cross the blood-brain barrier, even if the meninges are inflamed, and those include aminoglycosides and cefoperazone and first and second generation cephalosporins, except ceftriaxone, which is second generation. Clindamycin, you know that we use clindamycin for gram-positive bacteria. It has got limited effectiveness against gram-negative, okay? And same with linezolid, and vancomycin is also for gram-positive. Right, so let's look at antibiotic therapy for neonates to 1 month of age. In the first month of life, we have seen that it is strep A galactiae, which is group B, and it is also beta hemolytic. So group B and beta hemolytic streptococcus A galactiae or enterococci like Faecalis and Fishium. These are the common bacteria. Listeria monocytogenes was also there. And Enterobacteriaceae, for example, E. coli, this Listeria monocytogenes is there. So primary treatment consists of a combination of ampicillin was there, particularly for this one, monocytogenes. Cefotaxime was there. Gentamicin could be given, at this age, neonates age less than 1 month. First, the blood-brain barrier is not very well developed. So many drugs that do not cross the blood-brain barrier in adults will cross in this very early age, okay? So we have got cefotaxime and ampicillin and gentamicin. Acyclovir is obviously for herpes simplex virus. And, this is the age 0 to 30 days, 7 days. The doses are given over here, but the doses will not be asked from this table, okay? So let's put this is for your reference. When you go to your clinics, to your internships, you will need these doses. People are going to ask you there what the doses are. So for children, for babies 3 months to 7 years, obviously 3 months is babies, 7 years are kids. So the most common microorganisms are S. pneumonia and Neisseria meningitidis and H. influenza, and we have got vaccines for all of these. So primary treatment consists of cefotaxime and ceftriaxone. So cefotaxime, ceftriaxone, the doses are given. Now there is one more thing that we look at, which is drug-resistant strep pneumonia, where whether the prevalence is more than 2% or whether the prevalence of drug resistance is less than 2%. That is what we look at. How do we know? We have the data from our hospital antibiograms or from the geographic region where we are working or treating the patients. We know the prevalence of drug resistance over there, okay? So the dose of vancomycin and penicillin, the pediatric doses are given, milligram per kilogram. In cases of penicillin allergy, you can use chloramphenicol, vancomycin, and dexamethasone is there 0.4 milligram or 0.15 milligram. There are two doses. They will come in later slides as well. So DRSP stands for drug-resistant strep pneumonia. Now we go on to age 7 to 50 years, and again we are looking at drug resistance of strep pneumonia. And when the prevalence of drug resistance is more than 2%, then obviously not a big difference in the antibiotics, okay? The most common organisms are again S. pneumonia, N. meningitis, H. influenza, Listeria monocytogenes. H. influenza is not here, but Listeria monocytogenes is there. It should be there. Anyway, primary treatment consists of either cefotaxime or ceftriaxone plus vancomycin, right? So these three drugs, adult dosing, pediatric doses. See, adult doses are pretty high, 2 gram, pretty high doses. In cases of severe penicillin allergies, chloramphenicol, clindamycin, meropenem. And some people add rifampin as well. The pediatric dose is given. It's written 20 milligram, but many books write 10 milligram. So maybe in some later slide also you will see 20 milligram per kilogram, but more commonly it is 10 milligram per kilogram. All right. Okay. So that was in patients who are 7 to 50 years, and the prevalence of DRSP is more than 2%. Now, same age 7 to 50 years, the difference is here the prevalence is less than 2%. Okay, and the common bacteria are S. pneumonia and meningitis and Listeria monocytogenes. The drugs are the same, cefotaxime, ceftriaxone, plus ampicillin, okay? Ampicillin covers Listeria monocytogenes. So here are the pediatric dosing, adult dosing, same drugs. This TMP-SMX was not there in the previous slide. If you look over here, see there is clindamycin and meropenem. And here also we have meropenem, chloramphenicol, but this one is different, okay? So this is the pediatric dose. And again, dexamethasone is there. We will discuss a little bit the rationale for giving dexamethasone, but remember that it's given before initiating the antibiotic treatment. See, it's written 15, administer 15 to 20 minutes before the first dose of antibiotics. Now for patients who are 50 years, or adults with disabling disease or alcoholism, the most common microorganisms are S. pneumonia, H. influenza, E. coli, Listeria species, Pseudomonas, N. meningitis, most of them are same, these three or four you are quite familiar with. These four are almost there in all cases. Even E. coli we have seen previously. All right, and Pseudomonas, the gram-negative, if the gram stain is negative, then we should cover Pseudomonas as well. So if the prevalence of drug-resistant strep pneumonia is greater than 2%, then cefotaxime, ceftriaxone, 2 gram every 4 hours. So pretty high, how much is it every 4 hours? That means you give 2 gram IV every 6 hours, so 12 gram in a day. Plus vancomycin, this is also pretty high dose, okay? So if CSF stain shows gram-negative, then ceftazidime, which covers Pseudomonas, okay, this one Pseudomonas aeruginosa. In areas with low drug resistance to strep pneumonia, again, the dose is the same, 4 hours in ceftriaxone, 2 gram every 12 hours, but plus we have got ampicillin in place of vancomycin, okay? And the other options are meropenem, TMP-SMX, trimethoprim, sulfamethoxazole, and doxycycline. Right, so here is a comparison of all these 5 slides. It will be good for you. If you take a look at this slide, cefotaxime, ampicillin, neonates, or age 1 up to 1 month, then age 3 years to 7 years, and then 7 to 50. And we are looking at the prevalence of drug resistance as well, more than 2% or less than 2%. So you can compare the antibiotics and you can see that they are more or less the same antibiotics, only minor differences. Okay, so antibiotic therapy over 50 years. The Infectious Disease Society of America guidelines recommend adjunctive dexamethasone therapy in patients with suspected or proven community-acquired bacterial meningitis, but only in high-income countries. Why in high-income countries, I really do not know, but that's what it's written. That is what is written in the guidelines. The first dose of dexamethasone, which is either 0.4 milligram or 0.15 milligram per kilogram every 6 hours, is given 15 to 20 minutes before the first dose of antibiotics. Dexamethasone should be continued if culture grows either as pneumonia or H. influenza. However, some experts advise that adjunctive treatment should be continued irrespective of the causative bacterium. So you see, there is controversy in the use of dexamethasone. Okay. Anyway, but the guidelines say that dexamethasone should be given. Okay, I think I'll show you that in the next slide or somewhere. Yes, here it is, steroid therapy. The use of corticosteroids, typically dexamethasone 0.15 milligram per kilogram every 6 hours as adjunctive treatment for bacterial meningitis, improves outcome by attenuating detrimental effect. Now, now we are coming to overreaction of the immune system or overproduction of the cytokines. These steroids, they suppress the immune system. So in case where the immune system becomes unnecessarily too active, you have seen that in many diseases. You have heard of the cytokine storm, when then you have done that in sepsis as well, dysregulated immune response, right? So this will control that to some extent, the steroids. So it will protect from the detrimental effects of inflammatory response to the bacterial products and the products of neutrophil activation, which are, these reactive oxygen species. Okay, the neutrophils, the poor neutrophils, they make the reactive oxygen species to kill the bacteria, but they are damaging to the normal cells as well and to the neurons as well. So dexamethasone may interrupt the cytokine-mediated neurotoxic effects of bacteriolysis, which are at a maximum in the first days of antibiotic use. The anti-inflammatory effects of steroids decrease blood-brain barrier permeability, but still we get sufficient level. We do get the therapeutic level of antibiotics in CSF, okay? Because the permeability increases with inflammation. If you suppress inflammation with steroids, the permeability will decrease, okay? But the thing is that our observation is that we do achieve therapeutic levels of antibiotics, okay? And they do achieve the minimal inhibitory concentration in CSF, regardless of steroid use. So the use of steroid has been shown to improve the overall outcomes with certain types of bacterial meningitis, which includes H. influenza and tuberculous meningitis and pneumococcal meningitis. And this meta-analysis was done. Corticosteroids significantly reduce hearing loss and neurologic sequelae, but did not reduce overall mortality. So, different studies have got different findings, slightly different findings. However, there was a trend towards lower mortality. Here it says did not reduce mortality. Here it says lower mortality. So, different studies have got different populations. They're done in different centers. So the results are sometimes slightly different, okay? So lower mortality and reduced severe hearing loss, so they prevent, to some extent, they prevent hearing loss. In H. influenza meningitis and strep pneumonia meningitis, there they reduce the mortality. Although some studies have concluded that the benefits of dexamethasone are unproven, the guidelines recommend the use of dexamethasone except in neonates, and these are the World Health Organization guidelines and British guidelines. Okay, so although it is controversial, but most of the people do use steroids. Now, intrathecal antibiotics, which is given, intrathecal means in the cerebrospinal fluid, in the subarachnoid space, or in the ventricles of the brain, right? Intrathecal administration of antibiotics can be considered in patients with nosocomial meningitis after neurosurgery or placement of an external ventricular catheter, although to administer these intrathecal antibiotics, you have to use a catheter to administer the antibiotics in the subarachnoid space. And then, although FDA has not approved any antibiotic for intraventricular use, some antibiotics are often given, which includes vancomycin, gentamicin. We know it doesn't cross the blood-brain barrier under any circumstances. Amikacin, polymyxin B, colistin, so many different antibiotics could be given. And obviously the decision will be made by the infectious diseases doctor and the pharmacist. So change JABs to TABs, which means switching over from intravenous to oral medication. So here I've given the indications for IV therapy, lots of indications: severe sepsis, bacteremia, febrile neutropenia, deep abscess. So meningitis is there. So this is good for your reference. What is the benefit of switching over to oral antibiotics? It will reduce the cost, reduce workloads, reduce patient stay, all right, because the patient can take oral antibiotics at home as well. This is what is important, switch to from IV to oral. It is known as IVOS, okay, early IV to oral switch. So temperature 30, less than 38 for 48 hours. Patient clinically improve. You can tell, when the patient is improving. As I always say, that the appetite will improve, the patient will look better, the patient will become more energetic, he will talk more, he will smile, the toxic look on his face will go away, right? And he will be able to tolerate oral food fluids, so, and the WBC count and C-reactive protein and the ESR, if they will start falling down, okay, they will go down. So all these are good indications for switching over to oral medications. And this you can keep for your reference. For example, this is STOP algorithm. Patients with negative blood cultures who have received more than 48 hours of IV therapy may be eligible to stop or switch to oral therapy, right? So S stands for signs and signals, signs of clinical improvement. And these are the signs of clinical improvement that I've shown you previously. It will be good if you read that, but these slides are for your reference, If it is no, then you will continue with IV antibiotics and review therapy investigations, okay? And then if the signs are there, then you go on to T, and T stands for whether the patient is able to tolerate oral medications or not. And these are the signs, patient is not nil by mouth tolerating food, right? So you can read on their own. If it is not, then reconsider again after 24 hours, okay? Continue IV for another 24 hours. If it is yes, then you go to O, which stands for oral option available. And I'll give you, common oral antibiotic options. I'll give them to you in the next slide, okay? If the answer is yes, then you go on to P, which is possible to switch indications for prolonged therapy, which is in box 4. So if the answer is no to both these, then you continue IV treatment and you continue monitoring and reviewing the patient and again and again evaluating whether it is suitable to switch over to oral medications or not, right? So this OP are from the previous slides. And if all of these are yes, then you should um, you should reevaluate whether you really need antibiotic or not, that, or is it the time to stop antibiotic therapy? If the answer is no, then is antibiotic therapy still required? If it is not required, then you stop antibiotic, okay? And here are some common oral antibiotic options. They are given over here, but these slides are for your reference, okay? And if the answers are yes, yes, yes everywhere, all the conditions are fulfilled, then you switch to oral therapy, okay? So this is see box 3. These are your choices. And box 4 are indications for prolonged parenteral therapy. There are some infections where you have to give parenteral therapy for a pretty long time. Okay, then switch to treatment of viral meningitis. I'll not go into the details. The slides are there, and I've given you the drugs and the viruses that can potentially cause meningitis. So they're just two herpes simplex virus 1 and 2 and cytomegalovirus, okay? So this is for your self-study. I'll not read them. Prevention is important. As I said that we have got 3 vaccinations, H influenza, type B vaccination, and meningitis serogroups A, C, Y. This vaccine is available. Serogroup B vaccine is available. We have got 2 types of pneumococcal vaccines, 13-valent, which is given as part of routine childhood immunizations. This one is also these days included in childhood vaccinations. Then we have got a 23-valent pneumococcal polysaccharide vaccine, and that we give in children aged 2 to 18 years with some underlying medical conditions, okay? Then we have chemoprophylaxis, and for chemoprophylaxis, we use rifampin 10 milligram. Maybe in your handout, it's written 20 milligram, but change that to 10 milligram because that is the standard dose mentioned everywhere. So in cases of H influenza and meningitis or S pneumonia, there are 2 ways, and the pediatric dose is 10 milligram per kilogram per day for 4 days, or 600 milligram every 12 hours for 2 days, all right? You can give this to close contacts, but before giving prophylactic antibiotic, you should consult a specialist doctor or pharmacist. And in general, we give rifampin. You've seen the doses: ceftriaxone, ciprofloxacin, azithromycin, which is usually given if there is penicillin allergy. For regions with reported ciprofloxacin resistance, or this is another situation, ciprofloxacin resistance, 1 dose of azithromycin, 500 milligram is recommended, all right? And these are the rifampin doses that I have already shown you. The only difference is that children younger than 1 month should receive 5 milligram per kilogram orally every 12 hours if they can tolerate that. And that is all for meningitis. And I would like to get a feedback from you. So thank you very much and see you next time.